Welcome. I hope you're having a wonderful day. We're going to be discussing laxatives and antidiarrheals. First, we're going to be discussing the laxatives. There are several classes of laxatives. The first 5 on this list are the old, tried, and true. The bottom 4 are newer agents that are multiplying rapidly. We are going to be talking about each of these classes individually. Your book does not have very much information on the last 4 categories. Bulk-forming laxatives include drugs such as methylcellulose, psyllium, polycarbophil, and wheat dextrum. As their name suggests, bulk-forming laxatives add bulk to the stools. This helps the stools transition through the bowel. More specifically, bulk-forming laxatives contain hydrophilic elements that draw water into the stools. The more water the stool has, the easier they move through the colon. More bulk in the stools also stimulates peristalsis. Side effects with bulk-forming laxatives include flatulence, abdominal distension, rarely gastrointestinal obstruction. However, bulk-forming agents are generally well tolerated. They should be avoided in patients with intestinal obstruction. There are no significant drug interactions worthy of note. Examples of stimulant laxatives include Biscodil and Senna. Stimulant laxatives work by stimulating the colon to secrete water and electrolytes from the colonic mucosa into the stools. In turn, this increases the volume of the stools while also contributing to peristalsis. Senna is broken down by the colonic bacteria into metabolites, which promote peristalsis, though the precise mechanism of this interaction isn't known. Other side effects occur that are common with all laxative classes: increased flatulence, abdominal pain, and abdominal cramps. As with other laxatives, stimulants are contraindicated in patients with appendicitis, acute surgical abdomen, fecal impaction, or intestinal obstruction. Previously, long-term use of stimulant laxatives has been speculated to be addictive and can create permanent injury to the colonic mucosa. However, the research does not support this premise. I believe that this information is different than your book. I do also want to add that the usual onset with oral formulations of Biscodil is 6 to 10 hours, possibly up to 24 hours. But the old adage states, take in the PM for a BM in the AM. Examples of hyperosmotic laxatives include lactulose, sorbitol, polyethylene glycol, and glycerin suppositories. Hyperosmotic laxatives are used to treat constipation, bowel preparation before surgical procedures and/or endoscopy, and in the treatment of hepatic encephalopathy, particularly lactulose. Hyperosmotic laxatives work by drawing water into the stools. Osmosis not only retains water in the stools, but it actually lowers the intestinal pH through bacterial fermentation into acids such as formic and acetic acid. It also helps stimulate peristalsis. Lactulose has the added effect of inhibiting the absorption of pneumonia, hence its role in the treatment of hepatic encephalopathy, where excess ammonia is the cause. Side effects of hyperosmotic laxatives include GI effects, flatulence, nausea, and abdominal cramps. Like with many other laxatives, there's a risk of diarrhea when the pendulum swings the other way. Hyperosmotic laxatives should be avoided in patients with intestinal obstruction. I do want to note that glycerin is among the safest laxative preparations available and is often used in infants and children. Examples of saline laxatives include sodium phosphate enema, which is the Fleet's enema, magnesium citrate, and magnesium hydroxide, which is milk of magnesia. Like hyperosmotic laxatives, saline laxatives draw water into the intestine through osmosis. This creates an increase in intraluminal pressure and a resultant increase in intestinal motility. Care should be exercised with individuals who are at higher risk for complications, including young children, individuals over 55 years of age, and those who are dehydrated, have kidney dysfunction, or inflammation of the bowel. Because the kidneys eliminate magnesium, magnesium-containing laxatives should be used with caution in the elderly and in patients with decreased renal function. Surfactant laxatives or lubricant laxatives are effective at preventing straining in high-risk patients. For example, those having rectal surgery, those in labor and delivery, those with stroke, hemorrhoids, hernia, or myocardial infarction. Lubricant laxatives include mineral oil and desiccated sodium, which is cholase. I'm going to talk a little bit about mineral oil first. Mineral oil coats and softens the stool and prevents reabsorption of water from the stool by the colon. Mineral oil can impair the absorption of fat-soluble vitamins, A, D, E, and K. The biggest problem with mineral oil is that it can be aspirated and cause lipid pneumonia when administered to young, elderly, or bedridden patients. Now, desiccated sodium or cholase is used a lot, but that doesn't mean it works. In fact, there's not good evidence that desiccated is effective for preventing or treating constipation. Lubiprostone or Amitiza is the only chloride channel activator. It activates chloride channels, producing a chloride-rich intestinal fluid secretion without altering serum electrolyte concentrations, and increases the motility in the intestine. It is used for chronic idiopathic constipation, irritable bowel syndrome with constipation in females older than 18 years of age, and opioid-induced constipation in adults with chronic non-cancer pain. It does not work well with methadone, however. Like most laxatives, the adverse effects include nausea, diarrhea, abdominal pain, abdominal distension, flatulence, and headache. Contraindications include bowel obstruction or severe diarrhea. It should not be used during pregnancy and in children. There are no significant drug interactions. Guanylate cyclase C agonists include linaclotide, which is Linzess, and plecanatide, which is Trulance. The mechanism of action is topical rather than systemic, and therefore interactions are unlikely. It elevates intracellular GMP and stimulates secretion of chloride and bicarbonate into the intestinal lumen, thereby increasing stool transit time. They are indicated in the treatment of chronic idiopathic constipation and IBS with constipation. They should be taken on an empty stomach 30 minutes before the first meal of the day. Adverse effects include diarrhea, abdominal pain, flatulence, abdominal distension, and headache, just like every other laxative. They should not be given to children less than 6 years of age. It is used off-label for 7 to 18-year-olds. It's not metabolized by the CYP P450 system and has few interactions. The peripherally acting mu-opioid receptor antagonists, or PMORAs, include alvamopan, methylnaltrexone, naldehyde, and naloxegol. They act as antagonists of opioid binding at the mu-opioid receptors in the gut. They are used for opioid-induced constipation in patients with chronic non-cancer pain. They too should be taken on an empty stomach at least 30 minutes prior to the first meal. Adverse effects include all the same, but hyperhidrosis or excess sweating is added. They are contraindicated in GI obstruction or increased risk of recurrent obstruction due to the potential for GI perforation. This might include conditions associated with localized or diffuse reduction in the structural integrity of the GI tract wall, peptic ulcer disease, diverticular disease, infiltrative GI tract malignancies, or peritoneal metastases. I might add that Relistor or methylnaltrexone can be given for treatment of opioid-induced constipation in patients with advanced illness or pain caused by active cancer, and that's by injection only. Serotonin 5-HT4 receptor agonists include prucalamide. There are others in this class, but they're not used for laxative purposes. This class of drugs activates selective serotonin type 4, or the 5-HT4 receptors, and promotes bowel peristalsis. The only indication is for chronic idiopathic constipation. Adverse effects include the usual, plus suicides, suicide attempts, and suicidal ideation. This table is the recommended order of treatment for constipation, but this is after lifestyle changes such as increasing water intake and increasing dietary fiber. The first-line agents include bulk-forming agents. I often recommend wheat dextrin or benefiber as it is the most palatable. It is in generic form too. Descosate sodium is also first line and is most effective at preventing straining at stool in high-risk conditions that we've previously reviewed, although its efficacy is questionable. Glycerin is used most often in infants and small children. Naloxegol and linaclotide or lubiprostone are first line for chronic idiopathic constipation or opioid-induced constipation. Key clinical considerations for laxatives. Certain adverse effects are common to all laxatives, and they include nausea, diarrhea, abdominal pain, abdominal distension, and flatulence. Laxatives should be avoided in appendicitis, acute surgical abdomen, fecal impaction, or intestinal obstruction. There is not good evidence that descosate sodium is effective for preventing or treating constipation. Dispel the myth that stimulants cause dependence. Reassure patients they can use stimulants daily long-term if needed. Lean toward Biscadil. It has the most evidence for safety with long-term use. Glycerin is among the safest laxative preparations available and is often used in infants and children. There are multiple new drugs available for chronic idiopathic constipation and opioid-induced constipation. Now we are going to move to the opposite, antidiarrheals. Antidiarrheals fall into two major groups, specific antidiarrheal drugs and non-specific antidiarrheal drugs. Opioids are our most effective antidiarrheal agents. By activating opioid receptors in the GI tract, these drugs decrease intestinal motility and thereby slow intestinal transit, which allows more time for absorption of fluid and electrolytes. We will only be talking about the first three and not paregoric and opium tincture. For primary care, there is little use for these agents. Diphenoxin is the major active metabolite of diphenoxylate. Because diphenoxin abuse is somewhat greater than that of diphenoxylate, diphenoxin is classified as a Schedule 4 product and diphenoxylate is a Schedule 5 product, and which means both of them have to be written with a prescription. The atropine that is present in diphenoxylate and diphenoxin is to discourage abuse. Doses of the combination that are sufficiently high to produce euphoria from the diphenoxylate and diphenoxin would produce unpleasant side effects from the correspondingly high dose of atropine. Because of the atropine, side effects include dry mouth, dry eyes, urinary retention, blurred vision, drowsiness, and dizziness. For loperamide, side effects include abdominal discomfort, constipation, dryness, drowsiness, and dry mouth. Your book states the opposite of what I'm going to say here. Loperamide, in approved doses up to 16 milligrams per day, are extremely unlikely to produce opioid-like effects. However, exceptionally high doses can cross the blood-brain barrier, reach central opioid receptors, and cause euphoria. As a result, loperamide misuse to counteract opioid withdrawal and abuse to achieve euphoria is growing. Loperamide is also known as the poor man's methadone. Subsalicylate is the active ingredient found in Pepto-Bismol and kaopectate. Bismuth subsalicylate includes the active ingredients of bismuth, which stimulates prostaglandin, mucus, and bicarbonate secretion in the stomach, and salicylate that inhibits prostaglandin and chloride secretion in the large intestine. The action of the salicylic acid and bismuth on diarrhea is not well understood, but it's thought to have an anti-inflammatory action and antacid and mild antibiotic properties. Users should be aware that bismuth subsalicylate may darken stools and the tongue. Since the name contains salicylate, it's no surprise that it contains aspirin. Hence, it's not recommended for children and adolescents with the potential for Ray's syndrome. The current formulation of kaopectate adsorbs water. That's AD as in dog. It adsorbs water along with bacteria and toxins, as well as helps to solidify loose stools. Instead of absorbing water, water adheres to it. Bulk forming agents make stools firmer and less watery. We have already discussed these with the laxatives. Rifaximin, or Xifaxan, is a semi-synthetic antibiotic that's only effective against non-invasive strains of E. coli. The drug's a derivative of rifampin and acts to block transcription of the bacteria. Therefore, it inhibits bacterial growth, and that acts to suppress diarrhea by altering the growth of the bacteria. It's recommended for traveler's diarrhea. It's also used for hepatic encephalopathy and irritable bowel syndrome with diarrhea. Here are the recommended treatment options for diarrhea. Start with loperamide for general diarrhea or rifaximin for traveler's diarrhea. For patients who cannot tolerate loperamide or for those with contraindications, an adsorbent or anti-secretory agent may be chosen. Anti-secretory agents such as bismuth subsalicylate or kaopectate should be used with caution in patients taking warfarin and should be avoided in children or adolescents with the flu. Thank you for your time and attention.